Okay, let's dive in. We're tackling neonatal surgery today, a really complex and honestly vital field.
It absolutely is. We're talking about surgery on the tiniest patients, often facing life-threatening conditions right from birth.
We've got a stack of source material here, focusing specifically on managing congenital anomalies and some acquired conditions in newborns. The plan is to really unpack this concept by concept.
Right, so you can grasp it with the kind of depth needed if you work in or around this area.
You mentioned it's highly specialized, part of pediatric surgery.
Exactly. Primarily dealing with those non-cardiac structural issues babies are born with, congenital anomalies, and also necrotizing enterocolitis, NEC, which is sadly common in preemies.
And understanding the why involves looking at the structures and the baby's unique physiology.
Precisely. You can't separate the two.
Yeah.
The surgical challenges and treatments only make sense when you consider both the specific anomaly and how a newborn's body actually works, which is very different from an adult's.
Okay, let's start at the beginning then. What causes these structural congenital anomalies? The sources lay out 5 main categories.
They do. First up are gene defects. Simple point mutations can have big effects.
Okay.
Then there are aneuploidies, that's having the wrong number of chromosomes, like Down syndrome, for example.
Got it.
Infections during pregnancy are another cause. The sources list things like toxoplasmosis, CMV, rubella.
Right. The Tourette H infections often come up.
Exactly. And teratogens, external factors. Think certain drugs, heavy smoking, alcohol use during pregnancy.
Uh-huh.
And finally, what the sources call late mechanical etiologies. These are issues that develop later, physically, like an ileal volvulus, a twist in the gut, causing an atresia, maybe linked to cystic fibrosis.
Or lung issues and diaphragmatic hernia.
Yes, the lung hypoplasia can be partly mechanical from compression, or loss of intestine in something called enclosing gastroschisis, where the abdominal wall defect itself starts constricting the bowel before birth.
The sources also really highlight insults during gastrulation. That sounds like a super critical early phase.
Oh, absolutely critical. Gastrulation is when cells are migrating and getting their basic instructions to form tissues and organs. An insult then, maybe a genetic hit or an environmental one, can disrupt multiple developmental pathways at once.
Leading to multiple problems.
Exactly. That's where you see syndromes involving anomalies in different systems. The sources specifically call out VACTERL association,
Vertebral, anorectal, cardiac.
tracheoesophageal, renal, and limb anomalies, that's VACTERL, and also charge syndrome,
Which stands for?
coloboma, an eye defect, heart defects, choanal atresia, blocked nasal passage, growth retardation, genital anomalies, and ear anomalies.
Wow.
And the key takeaway, as the sources stress with Table 18.1, is that finding one anomaly from these associations means you must systematically screen for the others. They often travel together.
Okay, so the causes are diverse. But you said the physiology is where things get really different for surgery. Neonates aren't just scaled down adults.
Not at all. Their bodies operate under completely different rules, especially when stressed by surgery. This fundamentally changes how we have to care for them.
So what are the key physiological and anatomical differences the sources highlight?
Well, there are several big ones. First, the airway. Just getting an endotracheal tube in is different.
How so?
Their head shape, the relatively large occiput, actually flexes the neck if you lay them flat. They have a large tongue relative to their mouth, and their epiglottis is long, high up, and more angled.
So standard techniques won't work.
Right. You typically need a straight laryngoscope blade, not curved. An uncuffed tube is standard because the narrowest point is lower down, and you need to keep the head in a neutral sniffing position, not extended like in adults.
Okay, airway challenges. What else?
The abdomen. It has its own quirks. The liver is proportionally very large and quite fragile, and the bladder actually sits higher up in the abdomen, not tucked down in the pelvis yet.
Implications for surgery.
Careful entry is paramount. And if you're operating near the midline, you have to actively find and ligate the patent umbilical vein, which can still be open and carrying blood for days after birth. You can't just cauterize it blindly.
Makes sense. Respiratory issues.
Very common, especially in preemies. Respiratory distress syndrome, RDS, due to lack of surfactant or chronic lung disease from prolonged ventilation. Their respiratory muscles fatigue easily, and inflammation is a problem.
So surgery has to work alongside respiratory support.
Absolutely. Surfactant therapy, oxygen, CPAP, mechanical ventilation, these are often part of the perioperative picture.
Cardiovascular system next. You said it's like a tightrope walk.
It really is. At birth, pulmonary vascular resistance is supposed to drop, But stress like hypoxia, high CO2, acidosis can make it shoot back up.
And that causes problems because...
Because the connections that normally close after birth, the ductus arteriosus and foramen ovale, can reopen or stay open. High pulmonary pressure then forces blood to shunt right to left, bypassing the lungs, leads to severe hypoxemia.
Wow. And blood pressure.
Their baroreflex, the system that detects and corrects blood pressure changes, is underdeveloped. So even moderate blood loss can lead to sudden, severe hypotension. You have very little reserve.
Okay, airway, abdomen, respiratory, cardiovascular. What's the fifth key area?
Fluids and electrolytes. It's a minefield. They have a natural diuresis, losing water right after birth, but also high insensible losses, especially preemies under warmers.
And their kidneys aren't fully up to speed.
Exactly. They're immature, tend to lose sodium, bicarbonate, glucose, amino acids, phosphates. Plus, very low glycogen stores mean they become hypoglycemic easily.
So managing fluids requires strict protocols.
Absolutely. NICU protocols are essential. Maintenance fluids need sufficient glucose, often 10%, plus carefully calculated electrolytes. You have to watch constantly for problems like hyperglycemia with hypernatremia, high sugar, and high sodium together. The sources specifically warn this combination increases the risk of brain bleeds, intraventricular hemorrhage, especially in preterms.
And replacing specific losses.
Critically important. Any fluid lost from an NG tube or a stoma needs replacing milliliter for milliliter, usually with a specific solution like 0.45% or 0.9% saline with added potassium chloride. You can just guess.
The sources also mention nutrition and temperature.
Yes. Nutritional deficiencies are a major concern, especially in preemies or babies with gut issues. Often, they need urgent central parenteral nutrition IV feeding because their gut isn't ready.
And temperature.
Huge issue. High surface area to body weight ratio means massive heat loss, and they can't shiver. Hypothermia quickly leads to coagulopathy, bleeding problems, and metabolic acidosis. So maintaining a warm operating room using warming blankets, warmed Winnie fluids, warmed gases is non-negotiable.
That is a lot to manage simultaneously. It really drives home the need for specific principles when operating on these babies.
Exactly. You need a clear framework. The sources list several key principles. Co-location with the NICU is ideal quick access, shared expertise.
Transfer needs to be meticulous.
Absolutely. If there's any chance of bowel obstruction, an NG tube must be in place and actively draining during transfer to prevent aspiration or further distension.
Surgery itself?
Needs to be efficient. Minimize anesthesia time, minimize exposure. A warm environment is paramount, as we said. Tissue handling has to be incredibly gentle. Everything is delicate.
Antibiotics.
Blood. Broad-spectrum antibiotics are standard. Blood must always be available, especially for any laparotomy.
And for the very sickest babies.
Operating right at the bedside in the NICU might be the safest option, and often involves using damage control principles.
Damage control, what does that entail here?
It means doing the absolute minimum needed to stabilize the immediate life threat, then getting out quickly. So for an acute abdomen, maybe you resect, obviously dead bowel, close off the ends temporarily, what's called clip and drop, and leave the abdomen open, covered with a vacuum dressing, a laparostomy.
And fix it properly later.
Exactly. Definitive repair, maybe creating a stoma or anastomosis, happens days later when the baby is physiologically more stable. It avoids a prolonged high-risk operation on an infant who can't tolerate it. Often involves a planned second look operation.
Got it. Other principles. Cautery. Positioning.
Use the lowest effective electrocautery setting to minimize tissue damage. And critically, for preterms, avoid the Trendelenburg position head-down tilt because it raises intracranial pressure and significantly increases the risk of intraventricular hemorrhage.
The sources also touch on the different abdominal incisions used.
Yeah, several options depending on the need. A common one is a right-sided transverse muscle-cutting incision above the umbilicus, but you have to be super careful of that big, fragile liver.
Midline.
Midline longitudinal is another option, but again, watch out for the high-riding bladder. There are also muscle-sparing approaches like a symmetrical supraumbilical cut or an omega incision.
And for specific things like diaphragmatic hernia.
Typically a subcostal incision on the affected side, usually the left.
What about minimally invasive laparoscopy?
The sources say it's suitable for stable babies with certain conditions, duodenal atresia, malrotation without an acute twist, ovarian cysts. But stability is key.
And the final point about nutrition access.
Crucial. If you anticipate any significant delay before the baby can be fed via the gut, establishing central venous access for parenteral nutrition early is essential.
Okay, that's a fantastic foundation. Let's move into the specific conditions, starting up top with esophageal atresia and tracheoesophageal fistula OA2.
Right. This is where the esophagus doesn't form properly, often with an abnormal connection, a fistula, to the trachea, the windpipe. The sources show 5 main anatomical types, like in figure 18.1.
How do they typically present?
Presentation gives clues to the anatomy. If the esophagus just ends blindly, with no fistula to the stomach, type A, the baby can't swallow amniotic fluid before birth. That often leads to polyhydramnios, excess fluid seen on ultrasound.
And afterbirth?
Immediate problems. Excessive drooling because saliva can't go down, choking or turning blue, cyanosis. With the first feed attempt, aspiration. The sources also note that in type A, because no air gets into the stomach via a fistula, the stomach might look small or be absent on X-ray.
Diagnosis and initial management.
Diagnosis is usually confirmed when you try to pass an NG tube and it stops coiling up in the upper pouch. You see this clearly on a chest X-ray. Initial management is all about preventing aspiration. A special double-lumen sumped tube, called a reclugal tube, is placed to continuously suction saliva from that upper pouch.
And a key warning about ventilation.
Yes, a major hazard. If a fistula is present connecting the trachea to the lower esophagus and stomach, like in type CDE, positive pressure ventilation, like bagging or mechanical ventilation, is dangerous. Air gets forced down the fistula into the stomach. Massive gastric distension. This pushes up on the diaphragm, making breathing harder, and can even lead to the stomach perforating. Figure 18.2 illustrates this risk well. If a baby with a fistula needs significant respiratory support, say for RDS, that fistula needs urgent surgical ligation.
Makes sense. What about the surgical repairs themselves?
It really depends on the type and the gap between the esophageal ends. For types A and B, the long gap atresias, a direct connection often isn't possible initially.
So staged procedures.
Often, yes. They might need a cervical esophagostomy, bringing the upper couch out to the neck to drain saliva, and a gastrostomy tube for feeding. The actual esophageal connection or replacement using colon, jejunum, or stomach might happen months later, though sometimes techniques using traction can bring the ends closer over time for an earlier repair.
And for the more common types with a fistula?
Types C and D usually have a shorter gap. The fistula is divided, surgically disconnected from the trachea. This is traditionally done via an open right thoracotomy, but thoracoscopic, minimally invasive repair is becoming more common.
Can you connect the ends right away?
If the baby's stable and the gap isn't too long, yes, a primary anastomosis is done, often sewing the ends together over a small feeding tube, a transanastomotic tube, that allows early feeds past the repair.
And if the gap is still too long?
Then options are similar to the long gap types. Delay the anastomosis until the baby grows, use traction sutures to try and bridge the gap sooner, or plan for a later interposition graft. Gastrostomy for feeding is essential in these cases.
What about type E, the H type?
That's usually an isolated fistula without atresia. It often presents later the baby can feed, but coughs and chokes during feeds, or gets recurrent chest infections because milk or saliva tracks into the airway. It's typically diagnosed with a contrast swallow study and repaired through a small incision in the neck.
And potential complications after any OTF repair.
Several possibilities. Anastomotic leaks can occur at the suture line. Minor ones might settle, but bigger ones need intervention. Esophageal strictures narrowing at the repair site are quite common and often require repeated stretching or dilation with bougies or balloons. And sometimes the fistula can reform, which needs another operation.
Okay, moving down the GI tract, duodenal atresia.
Mm-hmm.
What's the story here?
This is a blockage in the duodenum, the first part of the small intestine, usually just beyond the point where the bile and pancreatic ducts enter the ampulla of Vater.
What happens physiologically?
Amniotic fluid the baby swallows can't get past the blockage. So the stomach and the part of the duodenum just before the atresia get hugely dilated. The pyloric valve between the stomach and duodenum gets stretched and often becomes incompetent.
The sources mention a windsock.
Yes, and sometimes the blockage isn't a complete separation, but a thin membrane or web that bulges downstream with pressure, like a windsock. This can be important surgically.
How is duodenal atresia typically identified?
Often suspected antenatally on ultrasound due to the dilated stomach and duodenum. Postnatally, a plain abdominal X-ray confirms it by showing the classic double bubble sign.
Double bubble?
Yeah, figure 18.3 shows it well. One bubble is the air-filled stomach, the other is the air-filled dilated proximal duodenum separated by the pylorus. It's quite characteristic. If it's missed somehow, the baby presents very quickly with bilious green vomiting because the bile entering the duodenum can't get past the blockage.
Can there ever be gas further down?
The sources mention it's possible, though rare. If the bile pancreatic duct openings are arranged unusually around the atretic membrane or windsock, a tiny bit of air might sneak past. But the double bubble is still the key diagnostic feature.
And the surgical fix?
The standard operation is an open Kimura duodenal. Figure 18.4 shows the approach. It essentially creates a diamond-shaped connection side to side between the dilated duodenum above the blockage and the collapsed duodenum below it, bypassing the atresia.
Is a tube sometimes placed across it?
Yes, sometimes a transanastomotic tube is threaded across the repair to help decompress the area and potentially allow for early feeding into the downstream bowel.
Okay. What about small bowel atresias occurring further down?
These can happen anywhere in the jejunum or ileum. They can be single, isolated blockages, as shown in figure 18.5, or sometimes multiple.
What's thought to cause the isolated ones?
The leading theory, mentioned in the sources, is a localized vascular accident after the gut has already formed. Like a small segment loses its blood supply temporarily, perhaps due to a twist or clot, and that segment gets absorbed, leaving a gap or blockage.
Are there other causes?
Yes, there's a rare genetic form causing multiple intestinal atresias, sometimes linked to immune deficiency, associated with TTC7A gene mutations. Also, a segmental ileal volvulus can cause an atresia. And the sources note that the very thick meconium in cystic fibrosis is a risk factor.
What's the main challenge surgically with this?
The big issue is the size mismatch. The bowel upstream of the blockage becomes hugely dilated, thick-walled, and doesn't contract well. It's dysmodal. The bowel downstream is unused, collapsed, and tiny, sometimes called microcolon if it affects the colon too.
Could you just sew the ends together?
Sometimes. If the size discrepancy isn't too extreme, maybe up to a 5-to-1 ratio in diameter, a primary anastomosis might be possible. Often, the surgeon needs to resect some of the dilated, poorly functioning bowel proximal to the atresia, provided you don't sacrifice too much overall bowel length.
And if the size difference is too great?
Then a staged approach is often safer. Resect the atresia, bring the upstream end out as a temporary stoma, and the downstream end out as a mucus fistula. This allows the baby to be fed, the proximal bowel decompresses, and the downstream bowel can be stimulated or grow over time before attempting an anastomosis later.
Got it. Next up, malrotation and volvulus. This sounds urgent.
Extremely urgent, potentially life-threatening. Understanding normal gut rotation is key here.
Explain that.
In the fetus, the gut undergoes this complex 270-degree counterclockwise rotation. The end result, normally, is that the mesentery, the fan-like tissue attaching the small bowel to the back wall of the abdomen, gets a very broad base of attachment. It runs diagonally from the upper left near the stomach, the duodenojejunal flexure, DJ flexure, down to the lower right where the cecum sits. This broad base keeps it stable.
So malrotation is when that doesn't happen.
Exactly. If that rotation is incomplete, the mesenteric base remains narrow, almost like the bowel is hanging by a thin stalk. This narrow base is inherently unstable and allows the entire small intestine to twist around it. That's the volvulus.
And Ladd's bands.
Those are fibrous bands that can form in malrotation. Typically, they run from the cecum, which is often abnormally located high up in the central abdomen, across the duodenum to the right side of the abdominal wall. These bands themselves can compress and obstruct the duodenum, as shown in figure 18.6.
How does malrotation present?
It can be chronic or acute. Chronic volvulus, maybe twisting and untwisting without cutting off blood supply completely, might present subtly failure to thrive, malabsorption, maybe protein-losing enteropathy, or chylocystitis.
But the acute form?
That's the emergency. Acute volvulus means the twist is tight enough to obstruct the bowel lumen and compromise its blood supply. The cardinal sign, the absolute red flag the sources emphasize, is green bilious vomiting in a newborn. Figure 18.7 shows the potentially catastrophic outcome, ischemic bowel. This requires immediate intervention.
So how do you manage a suspected acute case?
If you have a baby who looks sick, maybe acidotic, is vomiting bile, and maybe has a scaphoid gasless abdomen on x-ray, you don't wait for more tests. It's straight to the operating room for an immediate laparotomy. Time is bowel.
And if the baby seems well, but has bilious vomiting?
Then you have a bit more time. An upper GI contrast study is the investigation of choice. You're looking for the position of the DJ flexure. If it's not in its normal spot to the left of the spine at the level of the pylorus, then malrotation is likely, and the mesentery is probably unstable.
What does the surgery, the Ladd's procedure, involve?
First, if there's a volvulus, you gently untwist it. Then, you perform the LADS procedure itself. This involves dividing those LADS bands that might be obstructing the duodenum. Crucially, you then broaden the base of the mesentery as much as possible to prevent retwisting. You typically place the small bowel entirely on the right side of the abdomen and the colon on the left, as shown in figure 18.8.
And the appendix.
The appendix is usually removed during a LADS procedure. Because the cecum ends up in an abnormal position, usually the left upper quadrant, appendicitis later in life could present very unusually and be difficult to diagnose. So prophylactic appendectomy is standard.
Okay, moving on to meconium ileus, strongly linked to cystic fibrosis, you said.
Yes, it's considered pathognomonic for CF until proven otherwise. It's caused by abnormally thick, sticky, inspissated meconium blocking the distal ileum.
Can it cause complications itself?
It can. The blockage can lead to a secondary segmental volvulus, or even an atresia just proximal to the obstruction. If the distended ileum perforates before birth, the sticky meconium spills into the peritoneal cavity. This can seal off or persist, sometimes forming a large meconium pseudocyst walled off by inflammation.
Diagnosis.
Usually suspected based on abdominal distension and failure to pass meconium. A plain abdominal X-ray shows signs of low small bowel obstruction. Often you see a ground glass appearance in the right lower quadrant due to tiny air bubbles mixed in the thick meconium. If you see calcification within the peritoneum on the X-ray, that's a sign an antenatal perforation occurred.
How is it managed? Simple cases first.
For uncomplicated meconium ileus, meaning no perforation, volvulus, or pseudocyst, the first line of treatment is often non-surgical. A therapeutic enema using a water-soluble hyperosmolar contrast agent, like diatrizoate, gastrographin, is given under fluoroscopy. Figure 18.9 shows this. The high osmolarity draws fluid into the meconium, softening it and helping to flush it out. But the baby needs to be really well hydrated before you do this.
And complicated cases.
Those require surgery, a laparotomy.
Yeah.
You need to make an opening in the bowel, an enterotomy, usually in the dilated segment just above the obstruction, and physically wash out the tenacious meconium plugs. Sometimes a temporary ileostomy, stoma, is needed to allow for continued bowel decompression and irrigation post-operatively.
Any post-op tricks?
N-acetylcysteine, mucomist, is often used. It can be given down the NG tube or via the stoma or as enemas to help break down and loosen any remaining thick meconium.
And the CF link.
Absolutely crucial. Every baby diagnosed with meconium ileus needs genetic testing for mutations in the CFTR gene to confirm or exclude cystic fibrosis.
No, necrotizing enterocolitis, NEC, this one isn't congenital, it's acquired, right?
Correct. NEC is an inflammatory, sometimes necrotic disease of the bowel that typically affects premature infants in the NICU, usually after they've started feeds, typically several days or weeks after birth. The sources say it affects about 10% of preemies. Interestingly, it's noted as less common in exclusively breastfed babies.
Where in the bowel does it usually occur?
Most commonly affects the terminal ileum and the colon. Less commonly the jejunum, rarely the duodenum. It tends to be patchy.
How does it present? It sounds like a spectrum.
It is definitely a spectrum. Mild NEC might just be feeding intolerance, increased gastric residuals, bilious aspirates, some abdominal distension, maybe a little blood in the stool.
Management for mild?
Stop feeds immediately. Gut rest. Start broad-spectrum IV antibiotics. Provide nutrition via PN, parenteral nutrition, close monitoring.
Moderate NEC.
More significant signs: abdominal tenderness, signs of sepsis, like temperature instability, lethargy, increased oxygen requirement. These babies often need respiratory support, maybe inotropes for blood pressure. They are watched extremely closely, maybe needing surgery, maybe turning the corner with medical management.
And severe NEC.
This is a surgical emergency. Rapid deterioration, multi-organ failure, profound sepsis. The abdomen often becomes tense, shiny, and develops a dusky or reddish discoloration. Figure 18.9 gives an idea. Sadly, mortality is high, around 30%. Immediate surgical consultation is mandatory.
What do you look for on X-ray?
The hallmark sign is pneumatosis intestinalis gas bubbles within the bowel wall itself. Figure 18.11 shows this finding. Portal venous gas in the liver's blood supply is another ominous sign. And pneumoperitoneum free air under the diaphragm means the bowel has perforated.
Surgical management if needed.
It varies. Sometimes for a contained perforation or specific situations, just placing a peritoneal drain at the bedside might be enough, at least initially. But usually, for definite perforation or clinical deterioration despite medical management, laparotomy is needed.
What happens at laparotomy?
The surgeon assesses the entire bowel, looking for necrotic dead segments, like in figure 18.12. The goal is to resect only the clearly non-viable bowel. Then the decision is whether to reconnect the ends, primary anastomosis, or bring the ends out as stomas, usually an end stoma and a mucus fistula.
What about the damage control approach here?
Yes, for the very sickest babies who wouldn't tolerate a long operation, damage control is used. Quickly resect the dead bowel, temporarily close the ends, clip and drop, leave the abdomen open with a vacuum dressing, laparostomy, stabilize the baby in the NICU, then return to the OR days later for definitive surgery, usually stoma formation.
What are the long-term prospects after NEC surgery?
It depends heavily on how much bowel remains. The sources suggest survivors with more than about 40 centimeters of small intestine generally adapt well over time, eventually tolerating full feeds. But those with significant bowel loss, short bowel syndrome, face major long-term challenges, potentially needing prolonged hospitalizations or even home parenteral nutrition for years.
Okay, let's shift to biliary atresia and choledochal malformations, problems with bile drainage.
Exactly. Biliary atresia is a progressive inflammatory process that destroys or blocks the bile ducts outside and sometimes inside the liver. It can be congenital or possibly acquired, may be triggered by something like CMV infection.
Different types.
Yes, classified based on the level of obstruction. Type 3, involving the ducts right up at the base of the liver, the portal plate, is the most common, about 80% of cases.
How does it present? This sounds like something that needs picking up early.
Absolutely critical to diagnose early. The classic presentation is persistent jaundice beyond the first couple of weeks of life, specifically conjugated hyperbilirubinemia. A direct bilirubin test will be high, along with pale, chalky stools, because bile isn't reaching the gut, and dark urine as bilirubin spills into the urine.
Late sign.
If missed, the baby develops signs of chronic liver disease and malabsorption, poor growth, deficiency of fat-soluble vitamins leading to coagulopathy, bleeding. The sources mention associations like BAM syndrome and CMV again in Table 18.1.
Stenosis.
Confirmation usually comes from a HIDA scan, a nuclear medicine test that tracks bile excretion from the liver. If the tracer doesn't reach the intestine, it strongly suggests biliary atresia. The key message from the sources is urgency. Delay leads to irreversible liver fibrosis, cirrhosis, and death, usually within the first couple of years if untreated. Preventing sepsis is also vital.
What's the surgical treatment?
The standard initial operation is the Kasai-hepatico-portoenterostomy. This involves removing the remnants of the extrahepatic bile ducts and then sewing a loop of genunum, fashioned into a Roux-en-Y limb, directly to the fibrous tissue at the portal plate, the area where the bile ducts enter the liver. The hope is that microscopic bile ductules within that tissue will drain into the jejunal loop.
Does it cure it?
It can restore bile flow and prolong survival with the native liver for some years, but it's not usually a definitive cure. The sources state that a majority of children who have a Kasai procedure will eventually require a liver transplant later in childhood or adolescence due to progressive liver disease.
And choledochal malformations.
These are cystic dilatations, like balloons forming in the bile ducts. They also require surgery, typically resection of the dilated segment and reconstruction of bile drainage, often using a similar Roux-en-Y portoenterostomy or hepaticogynostomy.
Moving to the very end of the GI tract.
Yeah.
Anorectal malformations.
This is a spectrum of defects affecting the formation of the anus and rectum. The anatomy differs significantly between boys and girls.
How so in boys?
In boys, there's often no visible anal opening in the normal spot. The rectum might end blindly high up, this is more common with aneuploidies, or more commonly it ends with a fistula, an abnormal connection usually to the urinary tract, the bulbar urethra, the prostate, or even the bladder neck. Less commonly, there might be a rectoperineal fistula opening somewhere on the perineum near the normal anal site.
And in girls.
In girls, the most common forms are a rectovestibular fistula, where the rectum openly into the vestibule just behind the hymen, if figure 18.13b, or a rectoperineal fistula. A crucial point the sources make is that because meconium can pass through these fistulas, the diagnosis might be missed on a cursory newborn exam if you don't look carefully at where the stool is coming from.
What about a cloaca?
That's a severe form in girls, where the rectum, vagina, and urethra all fail to separate and join into a single common channel that opens onto the perineum, figure 18.13c. These are highly complex reconstructive challenges.
How are these typically managed? Sounds like complex surgery.
Often staged, especially for the higher anomalies. For boys with high fistulas, prostatic or bladder neck, the usual first step is a diverting colostomy, typically a divided sigmoid colostomy. This protects the urinary tract, allows the baby to feed and grow, and decompresses the bowel.
And defining the anatomy.
Yes. Before definitive repair, a contrast study called a distal colostogram, or lupogram, is done by injecting contrast into the downstream limb of the colostomy, as shown in figure 18.14. This precisely defines the height of the rectal pouch and the location of the fistula, which is critical for planning the repair.
And the repair itself.
Repair of the highest fistulae, prosphatic bladder neck, often involves a combined approach laparoscopic assistance from inside the abdomen plus work from the perineum. For prostatic and bulbar urethral fistulae, the standard approach is the posterior sagittal anorectoplasty, or PSARP, developed by Pena. This involves a midline incision through the sphincter complex to carefully dissect the rectum, divide the fistula, and bring the rectum down into the center of the muscle complex.
And the colostomy.
That's usually closed in a third operation several weeks or months after the main repair has healed.
What about the lower fistulas?
Perineal fistulas and some vestibular fistulas in girls can often be repaired with a primary procedure, like an anaplasty or transposition, without needing a protective colostomy.
Okay, Hirschsprung's disease next. A problem with bowel nerves.
Exactly. Hirschsprung's is caused by a failure of neural crest cells to migrate properly into the distal bowel during development. This results in a segment of bowel, starting at the anus and extending proximally for a variable distance, that lacks ganglion cells, the nerve cells needed for coordinated muscle relaxation and peristalsis.
Genetic links.
Yes, it's considered a neurocrestopathy and is linked to mutations in several genes, including URET, EDNRB, and EDN3. It can be familial.
What's the functional consequence?
The aganglionic segment of bowel remains tonically contracted, unable to relax. This causes a functional obstruction, leading to massive dilatation of the normal ganglionated bowel proximal to it.
How much bowel is typically affected?
The length varies. The sources state about 75% of cases involve the rectum and sigmoid colon, short segment disease. About 15% extend further into the colon, long segment, and about 10% can involve the entire colon or even extend into the small intestine, total colonic aganglionosis. A key feature is the transition zone, often visible on contrast enema or at surgery, between the narrow aganglionic segment and the dilated normal bowel above it, figure 18.15.
How does it present in newborns?
The classic triad is delayed passage of meconium, usually beyond 24-48 hours, progressive abdominal distension, and bilious vomiting. This is an emergency.
Initial management.
Resuscitation, NG tube for decompression, IV fluids, and often antibiotics because these babies are prone to Hirschsprung-associated enterocolitis, HAEC, a potentially life-threatening inflammation. Urgent bowel decompression via rectal washouts or irrigations is crucial.
How is the diagnosis confirmed?
The gold standard is a suction rectal biopsy done at the bedside. Under the microscope, you look for the absence of ganglion cells and the presence of hypertrophied nerve trunks in the submucosa. A contrast enema can also be helpful, often showing the narrow distal segment, the transition zone cone, and the dilated proximal bowel. But biopsy is definitive.
What about definitive treatment?
Sometimes, if rectal washouts are effective, the baby can be managed non-operatively for a period to allow growth before definitive surgery. If decompression fails, a leveling stoma is created. The surgeon takes biopsies during the operation, checked by frozen section, to find the point where ganglion cells first appear, and the stoma is sited just proximal to that in healthy bowel.
And the final pull-through surgery.
The definitive operation involves removing the entire ganglionic segment and bringing the normally innervated ganglionic bowel down to the anus, performing an anastomosis just above the dentate line. Several techniques exist: Swenson, Duhamel, Soavi procedures, or increasingly common transanal pull-through approaches. The goal is the same: remove the bad bowel, connect the good bowel to the anus.
Long-term outcomes.
Most children achieve reasonable bowel control, but the sources note that long-term issues are common. These can include persistent constipation, fecal incontinence or soiling, and recurrent episodes of enterocolitis, which requires prompt treatment.
Okay, let's switch to the abdominal wall defects. Gastroschisis and exomphalos. Starting with gastroschisis.
Gastroschisis is a full-thickness defect in the abdominal wall, almost always just to the right of an intact umbilical cord. Through this defect, abdominal contents, usually small and large bowel, sometimes stomach, bladder, ovaries, or testes, herniate out into the amniotic fluid. There's no covering sac. Figure 18.16 shows a typical appearance.
Any known risk factors?
The sources mention associations with younger maternal age, teenage pregnancy, recreational drug use, smoking, and maternal genitourinary infections. Seems to have an environmental component.
Usually diagnosed before birth.
Yes, typically picked up on antenatal ultrasound. This allows for planned delivery at a tertiary center with pediatric surgery and NICU capabilities. Vaginal delivery is usually considered safe.
What's the immediate care after birth?
Priority is protecting the exposed bowel. Avoid twisting the mesenteric base. The baby's lower body and the exposed viscera are immediately wrapped in sterile transparent plastic wrap or placed in a bowel bag to minimize heat and fluid losses. A large bore NG tube is crucial for gastric decompression. And aggressive 5e fluid resuscitation is started immediately. Fluid losses from the exposed bowel surface are enormous.
What does the bowel itself look like?
It often looks abnormal, thickened, matted, maybe covered in a fibrinous peel due to chronic exposure to amniotic fluid. Motility is often significantly impaired initially.
What's closing gastroschisis?
That's a complication where the abdominal wall defect itself starts to constrict around the base of the herniated bowel antenatally. This can compromise blood supply, leading to intestinal atresia or necrosis. Figure 18.17 illustrates this severe variant.
How is gastroschisis repaired?
Several strategies. If the defect is small and the bowel fits back easily without causing too much pressure, a primary closure might be done under general anesthesia soon after birth. This usually requires NICU admission and ventilation afterwards.
What if primary closure isn't possible?
More often, a staged approach using a silo is needed. A silo is a temporary covering for the exposed bowel, creating extra space. It can be formally sutured in place in the OR, often made of silastic sheeting, or, increasingly common, a preformed spring-loaded silo can be placed at the bedside without general anesthesia, as shown in figure 18.18.
How does the silo work?
The bowel sits in the silo, suspended above the abdomen. Gravity, gentle pressure, and time allow the bowel edema to decrease and the abdominal cavity to gradually accommodate the viscera. The silo is reduced daily until the bowel is fully back in the abdomen. Then the defect is closed, sometimes just at the bedside.
And feeding afterwards.
Bowel function takes time to recover. The term is ileus. The sources suggest parenteral nutrition is typically needed for at least 4 weeks, sometimes much longer, until the gut starts working well enough for enteral feeds.
Okay, now exomphalos. How is it different?
Very different. Exomphalos, also called omphalocele, is a defect right at the base of the umbilical cord. The key difference is that the herniated viscera are covered by a membrane consisting of peritoneum on the inside, amnion on the outside, with Wharton's jelly in between. The umbilical cord inserts onto this sac.
Types of zomphalos.
Generally divided into minor and major. Exomphalos minor is usually less than 5 centimeters, contains only bowel, and the liver is typically not involved. These are often relatively easy to close surgically. However, a critical point from the sources, table 18.1, is that even minor exomphalos has a high association with other anomalies, especially chromosomal abnormalities like trisomy 13-18 and genetic syndromes like Beckwith-Wiedemann.
And exomphalos major.
These are large defects, often containing a significant portion of the liver as well as bowel within the sac. Figure 18.9. The abdominal cavity is often underdeveloped, loss of domain.
How is exomphalos major managed? This sounds challenging to close immediately.
Often, immediate closure isn't feasible or safe due to the size and risk of abdominal compartment syndrome, dangerously high pressure inside the abdomen. The standard approach for large ones is conservative paint and wait. The intact sac is dressed with topical agents like silver sulfadiazine cream or medical-grade honey to prevent infection and promote epithelialization.
Skin grows over the sac.
Exactly. Over weeks to months, skin gradually grows from the edges over the sac membrane. Once it's fully covered, the baby essentially has a large ventral hernia, which can be repaired electively later in infancy or childhood when the baby is bigger and the abdominal cavity has had time to grow. If early closure is attempted for a major defect, extremely careful monitoring for compartment syndrome is essential.
The summary box in the sources really helps contrast them. Key takeaways.
Yes, summary box 18.1 is useful. Gastroschisis, right of cord, no sac, bowel, often damaged, associated with environmental factors, rarely other syndromes. Exomphalos, central defect at cord insertion, covered by sac, frequently associated with aneuploidy syndrome as other anomalies, often contains liver, especially major, often requires staged or delayed closure for large defects. Very different conditions requiring different approaches.
Right. Excellent summary. Let's move up to the chest now. Congenital diaphragmatic hernia, CDH.
CDH is a hole in the diaphragm, the muscle separating the chest and abdomen, allowing abdominal organs, stomach, bowel, spleen, sometimes liver, to herniate up into the chest cavity.
What causes it?
It's complex, linked to genes involved in diaphragm, lung, heart, and foregut development. This explains the common associations. Lung hypoplasia, underdevelopment, pulmonary hypertension, cardiac defects, and GE8 are frequent partners to CDH. About half have other anomalies too.
Why are the lungs underdeveloped?
The sources point to two reasons. Partly mechanical compression from the herniated organs squashing the lung during development, but also an intrinsic developmental problem with the lung itself, potentially linked to genes like FOG2 and JADA4.
Location of the hernia.
The most common type by far is a posterolateral defect, usually on the left side of Bachtelek hernia. Less common are anterior defects, Morgagni hernias.
Diagnosed antenatally, how do you predict severity?
Yes, usually diagnosed on prenatal ultrasound. Predicting severity is crucial for counseling. Factors include the lung-to-head ratio, LHR, compared to what's expected, sometimes total fetal lung volume measured by MRI, and key predictor. Whether the fetal liver has herniated into the chest, liver up is generally worse prognosis.
Postnatal management sounds intense.
Extremely. It's all about stabilizing the baby's fragile pulmonary circulation and avoiding crises of pulmonary hypertension. Immediate intubation, muscle relaxation, gentle ventilation strategies are key. Often use permissive hypercapnia and high-frequency oscillation to minimize lung injury.
What triggers the pulmonary hypertension crises?
Stress, hypoxia, hypercapnia, acidosis, they can all cause the pulmonary vessels to constrict violently, leading to right-to-left shunting, worsening hypoxia, and cardiac dysfunction.
How is the cardiac dysfunction managed?
Assessed with echocardiograms. Treatments aim to reduce pulmonary vascular resistance and support heart function. May include inhaled nitric oxide, prostaglandin E1, milrinone, other inotropes. For the most severe refractory cases, ECMO or ECLS, extracorporeal life support, might be needed as a bridge to recovery or repair.
When is the hernia actually repaired? It sounds like stabilizing the lungs comes first.
Absolutely. This is a key difference from traumatic hernias. In CDH, rushing to surgery to reduce the bowel does not improve lung function initially because the core problem is the hypoplastic lungs and reactive pulmonary vessels. Surgery is delayed until the pulmonary circulation is stabilized, which might be several days or even weeks.
Surgical approach.
Can be done through the abdomen or the chest, open or minimally invasive depending on the center and the baby's condition. The defect size varies hugely. Small defects might be closed with simple sutures. Larger ones require a patch, often conical silastic or prosthetic material like Gore-Tex to bridge the gap. Sometimes there's a hernial sac which might be removed or placated.
And the pulmonary airway malformations.
The sources group these congenital lung lesions into three main categories. First, congenital cystic adenomatoid malformations, CCAMs, now often called CPAMs, congenital pulmonary airway malformations. Second, bronchopulmonary sequestrations, BPS. And third, congenital lobar emphysema, CLE.
What's special about BPS?
Sequestrations are segments of abnormal lung tissue that don't connect to the normal bronchial tree and, crucially, get their blood supply from an anomalous systemic artery, usually coming directly off the aorta. They can be intralobar within a normal lung lobe or extralobar, a separate mass with its own pleura. Hybrid lesions with features of both CSAM and BPS also occur.
How do these malformations present?
Some, particularly large CCAMs or CLE causing overinflation, can cause severe respiratory distress or cardiovascular compromise, mediastinal shift right at birth, requiring urgent resection. However, the sources note that most are actually asymptomatic at birth, often detected on antenatal ultrasound or found incidentally later.
So, management for asymptomatic ones.
Imaging and management are often deferred for a few months after birth to allow the lungs to mature. Definitive diagnosis and anatomical delineation require cross-sectional imaging, typically a CT scan with contrast, which is essential to map out the lesion and, especially for BPS, identify that aberrant systemic arterial supply before any planned surgery.
The sources also briefly mention a couple of newborn tumors. Sacrococcygeal teratoma.
Yes, SCT is a germ cell tumor arising from the coccyx, tailbone, often diagnosed antenatally by ultrasound. They can be mostly external, mostly internal, pelvic abdominal, or have components both inside and out. Figure 18.20 shows an external one.
Benign or malignant?
Most are benign mature teratomas containing various well-differentiated tissues. However, some can contain immature embryonic elements or rarely overtly malignant components like yolk sac tumor.
Management.
Complete surgical excision is the goal. This is usually done via a chevron incision with the baby prone. A critical point the sources emphasize is that the entire coccyx must be removed along with the tumor, as leaving any coccygeal remnant significantly increases the risk of recurrence. Careful reconstruction of the pelvic floor muscles is also important.
What if it's large internally?
If there's a large vascular intra-abdominal or intrapelvic component, sometimes an initial abdominal approach is needed to ligate the main feeding vessel, the median sacral artery, before proceeding with the perineal excision. Post-op assessment of bladder bowel function is important, and the tumor marker alpha-fetoprotein, AFP, is monitored serially to detect recurrence.
And the other tumor mentioned, congenital mesoblastic nephroma.
This is the most common primary renal tumor of infancy, presenting as a large, palpable abdominal mass in a newborn. Some babies can have associated perineoplastic syndromes like hypertension, due to renin secretion, or hypercalcemia.
Diagnosis and treatment.
Imaging, ultrasound, CT-MRI helps distinguish it from other possibilities like multicystic dysplastic kidney or Wilms tumor, which is rare at this age. Treatment is surgical, complete nephroenterectomy, removal of the kidney and ureter. This is usually curative for classic CMN, although some cellular variants have a higher risk of local recurrence or metastasis.
So we've covered an incredible amount of detail on these neonatal conditions and surgeries. The sources conclude by asking why this matters beyond infancy, why adult surgeons need to know this.
It's a really important point about lifelong care. Two main reasons are given. First, although rare, some of these congenital conditions can actually present for the very first time in adulthood.
Like what?
Malrotation, causing intermittent obstruction or volvulus years later. A previously asymptomatic congenital diaphragmatic hernia becoming symptomatic. Or a congenital lung malformation only causing problems in adulthood. So, adult clinicians need to keep these possibilities in mind.
And the second reason?
Much more commonly, adults who had surgery for these conditions as neonates may present later with related issues or even incidental findings where knowledge of their history is crucial.
Examples.
The sources specifically mention adults who had repairs for anorectal malformations or Hirschsprung's disease often require ongoing specialized colorectal follow-up due to potential long-term issues with continence or constipation. And for women who had these conditions, involving a gynecologist obstetrician who understands their specific pelvic anatomy and prior surgery is vital for managing reproductive health. Similarly, someone who had an esophageal atresia off repair needs lifelong awareness and potentially follow-up with an upper GI specialist for issues like reflux, dysmotility, or strictures.
It really drives home that these neonatal interventions are just the start of journey.
Exactly. It highlights the need for understanding the long-term sequelae and ensuring appropriate, knowledgeable follow-up care transitions from pediatric to adult services.
We have certainly taken a very deep dive today, really unpacking the unique world of neonatal surgery based on this material. From the underlying causes and physiology to the specific conditions and intricate techniques. It's truly a field demanding incredible precision.
What stands out, I think, is the layered complexity. It's not just about the surgical steps, it's the deep understanding required, the genetics, the physiology, the anatomy, how incredibly vulnerable these tiny patients are, and how different they are from anyone else surgeons operate on.
And how integrated the care needs to be.
Absolutely. From antenatal diagnosis involving MFM specialists and genetic counselors through the NICU team, surgeons, anesthetists, radiologists, pathologists, and then potentially long-term follow-up involving various adult specialists, it's the ultimate team sport.
It really underscores that what happens in those first days and weeks profoundly shapes a person's entire life trajectory.
It does. And looking at all this complexity and the lifelong impact really prompts a question for the future, doesn't it?
Which is?
Given how far we've come, but also the remaining challenges and long-term issues, how might future innovations, perhaps in fetal surgery or gene editing for specific anomalies, or maybe breakthroughs in tissue engineering for reconstruction or improving long-term function, how might these continue to transform the horizon for children born with these conditions?
That's a powerful thought to end on. Definitely a lot to consider about where this field might go next. Thank you for guiding us through this incredibly detailed deep dive.